Thank you, Jerry. This is analysis and interpretation of clinical research data. And like several of my other talks I've given at this meeting, sort of my lessons learned in clinical research, and some of the things I've learned hopefully will be less useful for you. By way of disclosure, I have no financial interest in any of the products, which I don't plan on mentioning during this presentation. This was a study that was published in 2006 in the journal Ophthalmology. It's a very important study for those of us who do keratoprosthesis surgery because this provided good evidence-based data to support the usefulness of the keratoprosthesis, and was what we used to get insurance companies to pay for the device in the United States. And in this paper, there were several tables. This is two of them here, which they looked at the preoperative visual acuity of patients and then the postoperative final visual acuity of patients. Again, as part of the evidence to support the utility of the Boston keratoprosthesis. And that was actually part of the study. And when you're looking at keratoprosthesis surgery, you're looking at results, you're looking at vision, complications, and retention. What they discussed was the retention rate at an average follow-up of 8.5 months was 95%. But you see the follow-up goes from 0.03 months, which is 1 day, to 24 months. So not surprisingly, the K-pros were retained in those patients who had 1 day of follow-up. The causes of failure were blah, 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 blah. They did provide a Kaplan-Meier survival curve, so we could take a look at the number of retention failures over time out to the study about 24 months. So after this came out, I decided to publish my own series of keratoprosthesis outcomes, and so this was a paper I submitted to the same journal, to Ophthalmology, entitled Boston Type 1 Keratoprosthesis Improving Outcomes and Expanding Indications. Here's an abstract, and I reported the same things that the multi-center study did, which was final visual acuity, retention, and complications. You see here in the lower shaded area, if you can't read it, I'll read it to you. Talked about the preoperative visual acuities and an average follow-up of 14 months, range as slow as 1 month. The postoperative vision was improved over the preoperative vision in 90% of eyes. So looking at the final visual acuity for these patients. Overall retention rate was 84%. Average follow-up of 14 months, range anywhere from 1 to 43 months. And discussed other subgroups as far as retention, and again provided a Kaplan-Meier survival curve. So I thought, well, if the first paper was published, then this should be published. We have similar data analysis. This is a single surgeon series, which in many ways is more useful than a multi-center study. So this is the response I received from Ophthalmology. Your manuscript has been carefully reviewed and some revision has been recommended. Below are the reviewer's comments. If you're willing to respond with revisions, Ophthalmology will consider publication of your work. So here are the comments, and I think I want to read this to you because this is important. Apropos final visual acuity, it is best to report it at set time intervals. Please read the JABS AGO editorial on improved reporting of case series and the paper by Di Loretto on best and final vision from the archives. For other measures such as retention, reporting at set time points, of course, makes sense as well. So, for example, these data have little meaning absent some kind of time denominator. Quote, in a single surgeon series of 57 cases, Boston type 1 K-pro implantation in patients with unilateral and bilateral corneal opacification results in improved vision in 90% of eyes and an 84% retention rate. I'm not going to go through all of this, but suffice it to say the reviewer had a few comments. These are the general comments you see here. And then had some specific comments as well. I've enumerated these. We'll just keep going through these. And I don't know, for those of you who have published, tell me if you've ever seen quite this number of comments coming back from a single reviewer. Maybe you'll have 2, sometimes 3 reviewers. We're up to 35, up to 40, up to 45, up to 50, 55 specific comments after about 10 general comments. So, I mean, the fact that this article was published shows, I think, my stubbornness as far as responding to each and every one of these comments. But this is one of the editorials that the editor of Ophthalmology referred me to. And this is the article where I dug jabs, and I think this is a very good article for any of you who do clinical research to read. And I'll read this as one section. An analysis reporting the proportion of a series of patients with variable follow-up does not adequately account for the differential follow-up among patients and is a potentially misleading way to present data. Sir? Sir? Excuse me. Can you stop talking, please? Instead, the proportion of patients at presentation or study entry and the rate during follow-up should be reported. Similarly, an analysis in which the final visual acuity of a series of patients with variable follow-up is reported does not adequately account for the effective time and may also be misleading. Reporting the rates of rates of visual acuity events during follow-up, like falling below a certain threshold of vision, 20/50 or worse, is preferred. Alternatively, when there's nearly complete follow-up, reporting the distribution of visual acuity at specified time points, like at 1 year, 2 years, etc., is appropriate. Small case series should not be overinterpreted because of the effects of chance. I thought this was actually pretty sound, and obviously we did not follow that. And the multi-center study didn't follow that, and I didn't follow that in my original submission to the journal. This is the other article that I was referred to and I read as well. In their conclusion, despite potential bias with the use of best or final visual acuity outcomes, these endpoints alone were used in most studies published in the year 2000 in the 3 most commonly cited ophthalmology journals. Authors of clinical studies should consider avoiding the use of best or final visual acuity outcomes whenever possible to minimize possible data misinterpretation. If best or final outcomes are used, authors should consider discussing limitations of these methods. So here's a diagram, or a histogram, looking at the articles published in AJO, Archives of Ophthalmology, and Ophthalmology, 3 of the leading journals in our field, looking at the year 2000, and looking at the percentage of articles that used best in the clear box, final in the gray box, or interval in the light gray box, visual acuities. So they say we should be reporting interval visual acuity instead of best or final. What you'll see in each of these journals, a minority of these reports contain reporting of interval visual acuities. As a corneal specialist, I want to see how we did compared to our colleagues. We see in our area of ophthalmology, our neuro-ophthalmology colleagues are probably the best as far as reporting interval visual acuities instead of final visual acuities are best. In cornea, we're in the middle of the pack. Pediatrics bring up the rear, looking like almost always reporting final visual acuity instead of interval visual acuity. So this is the paper that was published after responding to all of those reviewer comments. Again, that was just one of the 2 reviewers. And you see I followed their advice, and I have in every publication since. So we're looking at preoperative and postoperative visual acuities, not final, not best, but at specified time points. And this allows me to compare my results to other authors who are publishing on their outcomes with Boston ketoprosthesis, looking at 1 year, what percentage of patients have vision of 20/20, 20/50, etc. And also we're looking at complications and retention. And so we see here, when you're talking about a rate, the mistake I made in that first paper was I talked about a percentage. The retention rate was 87%. That's not a rate. A rate takes into account a unit of time. So you have to say at 1 year, the percentage of K-pros retained was, for example. Or what we did in this case is looked at the number of ketoprostheses that had to be removed, called a retention failure rate, which was 9. And then looked at the cumulative follow-up in terms of time of all the patients who had a ketoprosthesis. In that case, the cumulative follow-up was 97 years. So now you can say that the retention failure rate is 9/79, or 0.11 per person year. That's the way you should report a rate. And that's the way I can compare my results to somebody else who does ketoprostheses. That's important, because if our postoperative managements differ, we want to see what's the incidence of infectious keratitis, for example, using my antibiotic regimen versus somebody else's. You really have to look at the rate of infectious keratitis in my series compared to the rate in their series in order to say which one may be better. We're looking at just complications without taking the extent of follow-up into account. You really can't make that comparison. So you see down here, because 4 ketoprostheses were removed in the first year after surgery, the 1 year retention rate was 90%. Because 5 more were removed in the second year, the 2 year retention rate was 61%. Now I can speak about a rate because I'm talking at a specific time period after surgery. And here we see the table of all the complications. Again, not just mentioning these, but breaking them down as far as when these complications occurred, so we can compare between studies. So what lessons did I learn from publishing what was my first publication of Boston ketoprosthesis? Many post-op complication measures, outcome measures, such as visual acuity and complications, are significantly affected by the length of follow-up. So the reporting of such measures at specified intervals after surgery removes bias associated with variable length of follow-up and allows for easier and more accurate comparisons of outcomes between different studies. The reporting of post-op complications in terms of rates, the number of events, or cumulative time of follow-up allows an accurate assessment of the event risk in a given study and permits the combining of data from different studies for, let's say, a meta-analysis. I want to thank you very much for your attention.